Hello everyone, I have got another MRCOG Part 3 station for you. This is also a post-op station. Now I want you to think about the answers before you listen to the answer from the presentation. So pause the presentation as after you read the question, just to allow yourself to think about the answer before I go through the mark scheme. I hope you'll find this useful, and if you do, then please give this video a thumbs up and subscribe to my channel if you haven't already, and also leave a comment below to tell me if you have been following these presentations and if they have been any good to you. So the case study is a 43 years old patient has undergone a total laparoscopic hysterectomy for symptomatic endometriosis 7 days ago. She's admitted with right-sided abdominal pain, and on examination her temperature is 38, heart rate is 105, her resp rate is 18, her blood pressure is 135/80. The surgical sites are all beginning to heal. She has normal heart and chest sounds, but there is diffused mild tenderness in the abdomen with normal bowel sounds. There's also quite severe right angle tenderness. You have 10 minutes to answer a series of questions from the examiner regarding the management of this woman. So you can pause the presentation here and just think about the case study. First question, what diagnosis are you considering and why? So the answer to this is pyelonephritis, the most obvious one, um, but also right ureteral obstruction or injury. Basically, pyelonephritis is the most obvious one. She's got temperature, she's got high heart rate, she's got tenderness, especially in the right angle. But because this is a post-op scenario, you also want to think a bit laterally. For questions like these, what diagnosis are you considering? You do want to give at least a couple of differentials with it. Just tells you that you are thinking laterally. And in this case, that would be right ureteric obstruction or injury. Question number 2, how would you initially manage and investigate the patient? So initial management in this case, they want you to say about sepsis. So things like you want to do blood cultures for this patient, you want to give them some IV antibiotics, give them some IV fluids, catheterize the patient so you can monitor the urine output. You also want to do blood tests like for blood count, see reactive protein, urea and electrolytes, lactate, and give oxygen to the patient. So the entire sepsis 6 you want to talk about. With the diagnosis as suspected, you want to inform the on-call consultant. You also want to consider doing a intravenous pyelogram, but maybe a CT scan with contrast would be more of a diagnostic one. And you can also speak to the consultant radiologist if you're unsure as to which modality of imaging you want to be doing, to discuss with them regarding your both differentials, and then take it from there. So after the imaging, a diagnosis of ureteric injury has been confirmed. So question number 3 is describe the course of the ureter and explain where the likely injury points could be. So the ureters arise from the pelvis of the kidney and descend into the pelvis over the psoas muscle to reach the brim of the pelvis. At this point, they go anterior to the common iliac vessels. At the level of the pelvic brim, the ureters can be damaged during ligation of the ovarian vessels. Beyond the pelvic brim, the ureters pass down the side of the pelvis until they run under the uterine artery, so that's water under the bridge. At this point, the ureter is between 1 and 3 centimeters lateral to the cervix and is the most common site of injury during hysterectomy. This can happen when the cardinal ligaments and uterine arteries are clamped, cut, and ligated. The ureters then run into the back of the bladder and anterior to the vagina and insert into the bladder trigone. The ureters can be damaged when running anterior to the vagina when the vaginal cuff is ligated. So the fourth question is, what would you do after care has been taken over by the urologist? So an incident form needs to be submitted and a serious case review needs to take place. You want to inform the patient as part of your duty of candor. You also want to follow the patient as an outpatient, but also keep reviewing her as an inpatient when she's undergoing further um, surgery to have this repaired or looked at. Well, that's it for now, and I hope you've also found this station useful, although it's quite a brief and almost like a straightforward one, but it's something that is good to practice and to think exactly in the sense of how the examiners want you to think. So whenever there is a complication or there is something unexpected that happens, you always want to do duty of candor to the patient. You want to document it. You may want to do an incident form about it. You may want to present the findings at a clinical governance meeting, which happens at a lot of trusts, and you would be aware of it, like a mortality and a morbidity meeting, or something of that nature. You always want to inform your on-call consultant, the consultant who initially operated the patient. So those would be the common kind of things. In terms of initial investigations, you always want to think about doing some blood tests and then followed with some sort of imaging to then try and diagnose the problem. But never underestimate the importance of good history taking and examination findings, because some of the stations will want you to elaborately ask, oh, I'd like to speak to the patient, I'd like to get more information about the pain the patient's got, or whatever, and then and also obtain some examination findings and obtain some some EWS score, for example. So those would be the things that would the examiner would have in hand, but only if you ask for those things, they'll reveal them to you. So without those things, sometimes it can be quite difficult to answer the question. So make sure that you have the basics with you. So like the history, the examination, the EWS score for the patient, and the common things after any post-op, surgery is infection, collection, hematoma, bowel injury, bladder injury, ureteric injury. Those are common things that you want to think about and rule out. Um, Now, if you did find this video useful, then please don't forget to give it a thumbs up and don't forget to subscribe to the channel and comment down below if you think this video was useful and you would like me to do more of these for you.